This morning, we have an exciting program set out for you. We are happy to have with us Dr. Quincy Almeida, Dr. Patricia Rosebush, Dr. Mandar Jog, and Aaron DeLucia, award recipient of our Graduate Student Scholarship Program. We are truly fortunate that they are part of our local Parkinson's community. Thank you for taking the time out of your busy schedules to be with us today. Of course, we do not do events like this without the support of our sponsors. AbbVie, Hearing Life, Synovian Pharmaceuticals, Apollo Cannabis Clinics, and Urban Polling, along with our local community foundations and United Ways, and of course, our generous donors. I want to thank each of them for supporting us today. This has been a tough year for Parkinson's Society Southwestern Ontario, along with many in the charitable and business sectors. I would like to thank everyone involved in our walk this year, Walk the Block. Your generosity has raised more than $256,000 in support of those living with Parkinson's. If you are unable to participate this year and would like to support the organization, please reach out to myself, Mark, or Jessica, and we can help assist you with a donation. Today will be nothing like we've ever done or ever attempted before, and I hope you enjoy it as much as we enjoyed the process of putting it together for you. As always, we look forward to your input and feedback and look forward to the time when we can all get together and do this in person once again. Without further ado, I'd like to introduce our moderator, Devin Box, invite you to sit back and enjoy today's conference. Thank you.
Good morning and welcome to the 2020 Regional Fall Conference presented by Parkinson's Society Southwestern Ontario. My name is Devin Box and I'm excited to be acting as your moderator for today's event. In just a few minutes, we'll be embarking on an educational journey into Parkinson's with 4 experts in their respective fields. Since the concept of a virtual conference is new to so many of us, I'd like to point out a few unique features that will enable you to enjoy and interact with today's conference and presenters. Throughout our time together, you'll not only be able to listen to, but ask questions of our experts. You can do this through the Q&A panel on the right-hand side of your screen. Our in-studio team will be monitoring this feed and sending questions to me on your behalf during our question and answer periods. Our segments will be broken up into 50-minute blocks, followed by a 10-minute break to give you an opportunity to stretch, get a snack, or enjoy the information being presented on screen. This will also allow our team to sanitize our set and ensure that all of our speakers and teammates are working in a socially distanced and clean environment. And if for some reason you miss a segment or are unable to catch all of the information provided, the entire conference is being recorded and will be made available via the Parkinson's Society Southwestern Ontario's YouTube channel later this week. Before I introduce our first presenter, the Parkinson's Society Southwestern Ontario would like to extend its thanks to AbbVie, Synovian, Hearing Life, and the many local community foundations and United Ways for supporting today's conference. Their support allows Parkinson's Society Southwestern Ontario to continue to provide programs and events such as this conference. Our first guest is very well known in our Parkinson's community. Dr. Quincy Almeida is the Director of Movement Disorders Research and Rehabilitation Center at Wilfrid Laurier University and is one of the leading authorities in movement science and rehabilitation in Parkinson's disease. His research has featured in the Toronto Star, the Globe and Mail, on CBC and CTV National News, as well as in Maclean's magazine. Currently, his research is focused on mechanisms underlying motor and memory impairments in Parkinson's disease and other movement and memory-related disorders. He has won several national and international awards, including the Parkinson's Society of Canada's Young Investigators Award, Canada's Polanyi Prize for Physiology and Medicine, the Queen Elizabeth II Diamond Jubilee Medal, and a North American Distinguished Scholar Award from the North American Society for the Psychology of Sport and Physical Activity. Dr. Almeida, thank you for joining us today. The floor is yours.
Thanks, Devin, and welcome everybody. I would normally say at this point, it's great to see so many people in the audience, except I can't see anyone. You're probably sitting in your pajamas at home, and I will assure you that I'm actually not in my pajamas. Possibly the last webinar that you saw with me, I might have been in my pajamas halfway down, and you just saw the shirt from above. But today we're going to be talking about advances in gait and motor symptom rehabilitation in Parkinson's. But I figured we would try and do this with the twist of thinking about what this means in the COVID world. Of course, everyone's had their challenges, and I'd like to share with you a little bit about some of the challenges that we've had in trying to do our research. As is my standard, you can see our contact information at the bottom. This slide is going to pop up at the end so that if you see some of the things that you want to be involved in, this is the way to get a hold of us. You can email us at that address or give us a call at our phone number there. Okay, so putting COVID into perspective. To start with, what I would like to do, and let's see if this hopefully works here. What I'm showing you here, I'm going to pause this for 1 sec. What I'm showing you here is something that I attempted to put together to track what happened in terms of the number of cases of COVID, and basically what you're seeing across the top here, each bar is representing the number of deaths globally related to these different causes. So as you can see right now in this timeline, around January 20th was the first diagnosed case of COVID officially. And you can see that these are other causes of death in and around January 20th. You can see liver at the top and traffic accidents as the #1 cause of death. I'm going to play this timeline, and it plays by day. And you'll notice that COVID isn't actually in here. What I will point your attention to, though, is that Parkinson's is about halfway up the list. And if I continue to play this, and I'm going to talk my way through this because COVID still isn't there by the end of January. It's not hitting the list because fire has caused 15,000 or so deaths at this point. But you're going to see that as we get closer to March, eventually we're going to see COVID pop up at the bottom, and very quickly you're going to see that COVID starts to raise itself up the ladder. You can see how quickly it's expanding compared to some of the other diseases and causes of death. And I track this up to the end of June, and you can see right at the end here that it is creeping up on, in fact, HIV. And I think this cuts off at about June 22nd or so. And at that point, you will be able to see that COVID just surpasses HIV as a global cause of death. Okay, so what does that mean? We're not here to talk about COVID, but let's try and put things into perspective. Parkinson's, if we look at diseases, it is listed as one of the top 5 causes of death globally. Malaria is one of the diseases that is higher. You also saw that HIV, it just surpassed towards the end of June. And what this tells us is that Parkinson's is, of course, the #1 neurological disorder that's on that list. And to me, that means that there's an urgency to find cures for things like COVID, for malaria, and of course, Parkinson's disease. My talk today is supposed to focus on, oops, I'm out of my slides. Sorry, 1 sec. My talk is supposed to focus on gait, and with gait is a fancy word for walking, and this little figure is supposed to try and demonstrate the idea of how we might be able to use walking from 15 years prior to diagnosis. 0 here on the scale represents the time of diagnosis itself, and what your clinicians are expected to do over 5, 10, 15, and 20 years of disease. So we call this first period the prodromal period, and prodromal basically means the time before you're actually officially diagnosed with disease. And you can see that the process could actually be up to 15 years earlier than your actual diagnosis. And we say that gait's important because looking at walking, we can see things like decreased arm swing unilaterally, difficulty doing dual task, which basically means being able to pay attention to a secondary thing like talking on your phone while driving. Hopefully you're not doing that, but if you are, certainly when we look at walking, we see some impairments in doing that. And this is detected, keep in mind, 10 to 15 years earlier than your official diagnosis of Parkinson's. At the time of diagnosis, we start to see things like difficulty with turning, decrease in step length, greater asymmetry between the left and right side, and these are the types of things that help us make the diagnosis of Parkinson's disease. As we get further into the disease, around year 5 or so, usually we're looking to try and treat these things. Freezing of gait, festination, variability, which means choppiness in your steps, tracking for falls and things like that. All of these issues we start to try and manage between 5, 10, and 15 years. And of course, as the disease progresses, these symptoms become worse and ambulation can actually be lost and you may end up in a wheelchair. Now, that's not to say that everyone's going to end up in a wheelchair, but it is important to track these things because my role as a researcher is to try and drive from our research what things the clinician up top here is supposed to be trying to look for, trying to manage, and that's what our research is focused on. Okay. Why is this important? As many of you know, most of my research is focused on how we can translate these basic understandings of mechanisms of disease into treatments. And exercise may be one of those important things that we sometimes forget about, but it is important, and especially thinking of COVID and how we've been locked in our homes, it is important to think about how physical activity can actually be an important piece of the puzzle. On one side, we have the symptoms of Parkinson's disease, and you can see this one cycle basically showing how symptoms can get worse over time. And why physical inactivity is in the middle is because with a lack of physical activity, you might expect to see some of these things get worse. For example, if you're not challenging your balance on a daily basis, then of course your likelihood of falling or your risk of falling becomes greater. At the same time, physical inactivity also leads to these issues: obesity, cardiovascular disease, late onset diabetes, and this cycle can also be fed by physical inactivity. So exercise may be a really important part of Parkinson's, and that's part of what we're going to try and talk about today. Let me address one thing first, and some of you saw me put these slides up on a webinar in the summertime, but in case not everybody had a chance to think about this, can Parkinson's be worsened by COVID? The truth is that we don't really know the answer, but at the same time, we could think to what happens with other temporary disorders. Infections generally worsen your symptoms over time, but it is temporary. So things like flu, urinary tract infections, pneumonia, those things can all affect how your medications work. It also makes you feel worse when you're basically slowed down. And there's obviously things that we need to look for. And one of the things that we are trying to make sure that physicians and neurologists are aware of is that there are definitely things to look for that could be related to Parkinson's, but they could also be related to COVID. The number one thing that we have been trying to inform the community of is loss of sense of smell. As many of you know, loss of sense of smell can be a symptom of Parkinson's, but it is one of the number one signs of COVID. And if you have a sudden loss of sense of smell, you should certainly think about doing that COVID assessment at home. Other things to look for: increased movement symptoms, greater motor fluctuations, and off time with your medications where your medications seem not to work. Those are the types of things that you might want to look for because COVID can sometimes impact your symptoms. If you're experiencing some of these issues, of course, speak to your physician or pharmacist. And certainly if you're managing cold and flu symptoms, keep in mind that some of the medications that you're taking could interact with the medications that you're taking for Parkinson's. For example, MAO inhibitors such as Azilect or Rasagiline. Okay, what about non-motor symptoms? I've got this little pictorial here, and the pictorial is supposed to help us think about the non-motor things that might actually get worse with Parkinson's. Of course, we're all stuck in our homes, so social isolation can be an issue. Is there anxiety and depression related to these things? And we have a speaker that's going to be talking about some of these issues. Lack of motivation when you're in your home and you're probably right now sitting in your PJs or possibly lying in bed watching this broadcast. These things all can be issues. When you're not using your memory and engaging in active conversations, cognitive and memory impairments can become more noticeable. And of course, emotional and mood fluctuations are things that we need to consider as well. Okay, so my question today is to try and figure out what are we supposed to do about these things, and can exercise be part of that prescription? This little pictorial here is supposed to try and demonstrate, and I'll just draw your attention to this black line right here, if I can draw properly. This is supposed to be a normal, healthy individual. If we look down here at the red line, this red line over the years, this is years of age at the bottom, so you can see approximately 65 years of age. You can see this red line represents somebody with Parkinson's. This is pre-symptomatic Parkinson's, or what I was calling prodromal before. And then overt Parkinson's means at the time of diagnosis, and you can see the progression over time means that we have more and more issues. And what this is related to in this slide is how much dopamine innervation we have following this curve and as we age. Notice that this red line can change to this line. It's a slight change with exercise, and that's part of the question that we're talking about. Even in healthy people, if you look at the normal healthy person, exercise can actually change your dopamine innervation. So, as many of you know, our research is focused on exercise, but we have certainly had some challenges. And one of the questions is how do we manage with Parkinson's disease when we're expected to physically distance, when we're expected to limit our face-to-face interactions, and how are we supposed to do the types of delivery that we normally do? I have this picture because when March pulled around and we wanted to do assessments of our people that were just finishing in exercise programs, we very quickly came to the university and said, no problem, we have a glass window. This is our medical reception window that you can see in this little image. And I said, no problem, I'm gonna stand behind this glass. I'll put up whatever memory pictures and things people need to do. I'll ask them to move their hands up and down and do all the things that I would normally do to assess them through the glass window. And I made the mistake of saying, I'm gonna open this little sliding window where people might hand in their health cards. And if they stick their hand through there, then I could take a blood sample. And immediately the university said, we are not doing this any further. So right now we are not doing face-to-face, and that leaves us with some questions. These are the questions that I'm going to try and answer. Is online assessment equivalent to in-person when we can't see the patients in person? Can telemedicine and research deliver the same experience as in person? And is exercise rehabilitation delivery online even possible? Okay, I'm going to start with a little example, and this is an example of one of the studies that we were doing at the time that COVID hit us. This is a double-blinded randomized clinical trial, and what we had is two different programs that are reasonably popular in Parkinson's disease. One of them is PD-SafeX, stands for Sensory Attention Focused Exercise. The other one is Rock Steady Boxing that you can see here, and this pictorial is supposed to represent how we had designed this study. So time zero, I keep losing my cursor, there we go. Time zero means the time that we would have done pre-assessments of the participants' symptoms, and Basically, at this point, we would have randomly assigned people to receive this PD SafeX treatment, or in the other group, receive rock steady boxing. They would have done this for a total of 10 weeks, and then there would have been a washout period. The washout period, you can see we would have done another assessment at T1 to see how these programs had improved or not improved the symptoms of Parkinson's. And then we would have used the washout period to be able to try and figure out if the symptoms returned back after another 10 weeks. So then you can see we're at a 20-week point, and at the 20-week point, this is T2 now, and T2 would be the people that had originally received the PD SafeX program would now be switched into rock steady boxing. The people that were originally in rock steady boxing would now be in PD SafeX. And then, of course, after 10 weeks, we would have a third time period, and that's 30 weeks later, where we would actually assess the symptoms again to see what sort of difference there is. So we've got basically an apples-to-apples comparison of when somebody receives one treatment and the other, and then which treatment essentially works better for them. Again, there's a washout period to see if those effects last, and that would have taken us to a 40-week end to this trial. But of course, you can imagine that with COVID hitting, we were stuck with not being able to get a lot of those last assessments done in person, and that was a real challenge for us. And we had to think very quickly and carefully about how we could keep people safe and conduct our analyses and assessments so that we weren't wasting the last 40 weeks of trying to do this trial. Okay, so here's one of the first things that we did, and this is thanks to one of our graduate students, Kishri Sangra-Pillay. She worked on creating an equation where, if you think about the typical assessment that we do with Parkinson's, there's things like postural instability and balance testing, which requires the clinician to be able to actually put their hands on your shoulders. We call this the retropulsion test. We pull the person back, and then we evaluate how many steps backwards they take. Things like rigidity, where the clinician actually has to feel your arms and legs and your neck to see how stiff they can feel your different parts of your anatomy. But those things, of course, you can't do them unless you're in person with a participant. So what we have here, this is a little bit of math. Remember y equals mx plus b from math class? This is the basic idea here that we should be able to predict somebody's score from doing the rest of the assessment fairly carefully if we have this equation that we apply to try and predict what total severity would actually be. So you can see these dots are all fitting quite nicely on this line, which means that if we did some assessments online, we would be able to predict what their total severity score is as if they are in person based on this equation. So this is one method that we've got now that we can use to try and evaluate total severity. And of course, total severity is important because that helps your neurologist and your physicians try and decide whether you need more medications or other things that need to be adjusted in the management of Parkinson's. The second thing we thought about is whether or not sensors might be able to replace your neurologist. Is there a way to get these types of assessments done of your clinical symptoms without the clinician actually being present to do the assessment? Here's one example. This is called a Kinesia 1 system, but there's many different examples of these types of sensors. In this case, you can see that we would put something like this on your finger or on your foot if we're actually doing walking. You would look off of a screen or off of your cell phone, and the cell phone tells you, do this movement, and at the same time, the system reads what your finger is doing, and it evaluates whether or not you're in the bad category, mediocre category, or doing the movement perfectly fine. So these are interesting technologies. There are pros and cons to this, and of course we're asking the question, can we get away with not seeing the neurologist in person? On the pro side, of course, we have objective assessments, and one of the issues with a neurologist doing the assessment or a trained evaluator is that there's always a potential for some sort of bias, in the sense that if I know that you've just been in some sort of treatment program, I might be biased in my looking for some sort of improvement. So when I say objective assessment, the idea is that a computer is not going to lie. It's going to measure how wide those movements are, how consistent they are. The other benefit is that they are continuous, and by continuous, that means that I could send you home with this sensor, and I could track, just like a Holter monitor for your heart, I could track your performance at home and be able to see what sorts of changes, symptoms, and things that I'm seeing over a 24-hour period, over a week period, etc. So that's the third category there, is in-home assessment. And of course, one value here is that this data can be accessed anywhere. So if something was detected in using these sensors, we could easily send this to a hospital or to your neurologist and that sort of thing. So of course, these are very sensitive and potentially useful measures. On the con side of things, though, there are some challenges. For example, purposeful movements might actually resemble symptoms. So imagine you're at home and you decide that you're going to have some type of smoothie, and you take the bottle of mixture and you give it a shake. Well, is that shake you shaking the bottle, or is that your hand starting to tremor? And how is the sensor going to recognize that? There are other people that might be walking, and as they're walking, they think, oh, shoot, I was going to get something else, I forgot my keys. They stop, they turn around, they go back. Does that mean freezing of gait, or does that mean they just decided to stop and turn in the other direction? So sometimes the sensitivity can actually be a danger. Battery life has been an issue with some of these things when we send them home, and then after a couple of days, the battery isn't actually working anymore. There's the question of too much data. How often are we supposed to be assessing patients? Do you want your neurologist or a researcher to be looking at 24 hours worth of data for a month? Is that too much data? Should we look at 1 day? How does 1 day compare to 7 days? There's a lot of variables there to consider. And of course, for those of you who have health trackers and pedometers and things like that, there tends to be an anxiety or obsessiveness with checking, oh gosh, look, my tremor is worse. And you may start to watch your symptoms more carefully as a result of having these sensors that are detecting things during the day. So maybe sometimes these sensors might be too sensitive. All right, we of course have these sensors ourselves, and some of you have participated in using these while I'm doing assessments at our facility. So what we're seeing here, this would be the rating that I would have done assessment-wise. This would be the actual kinesia sensor on your fingertips itself. And if, well, it depends on how you take this. You could say if the sensors were as good as I am, then we should expect each of these dots, which is individual people that have done the assessment, to be right on this red line to be a perfect match to my assessment. The other way to look at it is maybe the sensor is actually better than me. Either way, what we are seeing is that all of these purple dots are above the red line, which means that they are essentially detecting more symptoms. And this is something to take with a grain of salt as well. Does that mean that you're actually more severe than I would have said you were? Or does this mean that the sensors are just more sensitive in being able to detect things that perhaps I wouldn't detect with the naked eye? Okay, so those are some of the strategies that we've used when we aren't able to see people in person. But let's get back to our study of the double-blind crossover. What we've got here is disease severity. And what we're asking here is, can we actually decrease the symptoms of Parkinson's? So the higher up on the scale you are, the more severe your symptoms are. The closer to zero you are, of course, the better your symptoms are. And this is those time periods. The pre-assessment, after 10 weeks of receiving the first treatment, 20 weeks would be the washout period, 30 weeks and 40 weeks, you get the idea. So let's look at what happens at the beginning here, and I'll just get you to focus on these two lines right here at the start. This is rock steady boxing on the one side, And we can see that there's a slight worsening of symptoms after 10 weeks, 13%. And on the other hand, we have the PD SafeX program showing a decrease in symptoms of about 28%. So you can kind of see that the lines are going in different directions. But then the second question is what happens when we stop doing those programs? So when we stop doing rock-steady boxing, there is still a slight worsening, 7.4%, and we have to ask the question, is that real worsening of disease, or is that just the typical progression of Parkinson's? Even here, after the PD SafeX program, you can also see a worsening after 10 weeks of not doing exercise. Perhaps the message here is always make sure that you're doing some sort of exercise. Remember that this is a crossover study, and so in this crossover design, the people that were receiving the rock-steady boxing, they would have switched over to PD SafeX. You can see that the worsening has this nice drop. There's a 27.5% improvement, which is almost equivalent to the 28% that we saw with the other group. The people that were originally in PD SafeX, now you can see them in rock-steady boxing, and then again there's this slight worsening, 8.5%, which is pretty comparable to the 13.7 over here. And then the last part is to look at washout again, and unfortunately in both cases you can see that there's a little bit of loss of that progress when you stop for 10 weeks. So that's the motor side of things. That's the clinical assessment that you would normally get by your neurologist. The other question we wanted to ask, and this is a separate study that was published in April, that evaluates whether or not the non-motor symptoms can be improved by our programs. So in this randomized control trial, we have a sham group, and we also have a group that was doing the PD SafeX exercise. And what we're looking at here is, and I'll just get you to focus on these two colors, the blue and the red. Blue represents people who remained clinically anxious, and you can see that in the sham group, or the group that didn't receive the treatment, there's 47% of them that remained clinically anxious. In the exercising group, you can see that this number is less, which means that perhaps the exercise helped. The other number to pay attention to is this. 40% of people are no longer anxious after doing exercise, whereas there's only 13% in the sham group that would have reported no longer feeling clinically anxious. Okay, I'm probably going to get close to overtime, and these people are going to start to tell me to speed it up. So let's talk about what future directions we're planning based on some of the issues that we've been dealing with. I've got some pictures of some lovely students that are taking over this work. This is Charlotte Jarvis, and I'm introducing the names because if you're interested in this research, of course, you can use our phone number or email address, and you can ask to speak to Charlotte. Charlotte's undergrad thesis is focused on whether or not virtual or online exercise can actually get the same benefits as our in-person programs. So there's some benefits to this, of course. So COVID isn't always a bad thing. Normally our studies are available to those people. Well, they're available to anyone, but of course if we want you to come in 3 times a week, it can be challenging to come in 3 times a week to our center. I just watched a camera almost topple over. It's interesting. Balance of cameras. Okay. What this means for us, if we're doing online or virtual delivery of exercise, that means that people who live further away that expressed interest in exercise, or now you want to be involved in exercise, you can do it from the comfort of your home just as you're doing right now. There are some challenges with this. It's great that we can offer our exercise to a much wider part of southwestern Ontario, but at the same time, there's challenges with compliance. I can't tell right now how many of you are sleeping in bed with one eye open and listening to me. I can't tell if you would be doing exercise if I told you to do exercise right now either. It's also a little bit more challenging for us to make sure that you're in a safe environment where you're not going to fall over. And if you do fall over, we're not there to help you, whereas in the center we would be. But the overall goal, of course, with these types of experiments is can we achieve the improvements in both motor and non-motor symptoms if we have this online delivery? So the idea is that you'd have your computer open at home And similar to watching me right now, you'd have our exercise leaders delivering exercise, and we would still do the pre and post assessments to be able to see how the symptoms are changing. Second direction, and I'm happy to say that this one is funded by the Parkinsons Society, Southwestern Ontario. This is Kishri Sangrapillai. She's focused on how we improve gait in Parkinson's disease, and is there a difference if we treat cognitive versus sensory systems? And if we can improve cognitive function, does that mean that we can actually get gait improvements? Or is it possible that if we focus on sensory treatments, that we would get better gait improvements? So she's trying to put these two things together. I know that many people are concerned about memory impairments just as much as movement impairments in Parkinson's. And this type of study will surely answer this question. It's the goal of trying to hit the first gold 1A standard study in Canada on exercise. The third one, and this is an exciting direction for us as well. There's always been this question about when we see a decrease in symptoms, does this mean that we're actually slowing the progression of disease? Or does this mean that we're showing a decrease in symptoms, but it's temporary because, as you saw with those washout periods, sometimes the symptoms trickle back? Well, one of the only ways that we can truly show a change in the progression of disease is to do brain imaging. And we are fortunate to be part of a 30-site exercise trial that is running 28 sites in the United States, 2 sites in Canada, 1 is Alberta, and luckily the other one is us. So this trial, funded by the National Institute of Health, is going to allow us to actually do brain scans. And we used to talk about the inability to diagnose Parkinson's 100%. But with a DAT scan, we do have the ability to evaluate dopamine active transporters. And with this type of scan, we can look at before and after exercise to actually measure the volume changes in the brain. So that's a very interesting proposition for us, and we're excited to do this. There's good news and bad news to this study that's coming up. This is Ben Norman, by the way, who's will be in charge of this study. It is strictly for people that are newly diagnosed, which means that you can't be on medications at the time that you're receiving this treatment. It is also 18 months long, but for the potential of slowing the progression of Parkinson's, we are very excited about the prospect of this study. Any 3 of these people, if you're interested in these studies, of course, you can reach out to contact us. All right, I'm going to try and close. I will just remind all of you that while exercising is important, it is definitely important to keep washing your hands, keep that mask on, better safe than sorry for sure. And I'll end with this quote. Some of you have seen this, and you know that I'm involved with the Michael J. Fox Foundation. Michael would say, "I don't have any choice whether or not I have Parkinson's. But surrounding that, non-choice is a million other choices that I can make, and exercise is one of them." These are some of the sponsors of our research: the Canadian Consortium for Neurodegeneration, CFI, Canadian Institute of Health, the Michael J. Fox Foundation for Parkinson's Research, and Parkinson's Southwestern Ontario is also supporting our research. I will stop there. Here's our contact information, and if there are any questions, I will try my best to answer them.
Fantastic. Now we'll go to the moment everybody's been waiting for. I know you've been chomping at the bit to ask Dr. Almeida some questions. So our first one, we'll say thank you to Elizabeth for this. So Elizabeth asked, I've heard that it is important to go to a neurologist that is a movement disorder specialist. I'm wondering why, and what is the difference between a movement disorder specialist and a neurologist?
Okay, that's an interesting question. I would say that, let's start with the difference. A neurologist, a general neurologist, is trained in many different things and is responsible for many different types of disorders. So you can imagine that a general neurologist might have to deal with patients with multiple sclerosis, epilepsy, stroke, and Parkinson's. And They're very well trained, of course, but at the same time, if you're not focused on movement disorders and Parkinson's on a regular basis, it can be a little bit more challenging to keep up to date with all of the new discoveries and all the research that's coming out and new types of treatments and things like that. So movement disorder specialists are people that focus on Parkinson's disease and different disorders of the basal ganglia. I think there's several advantages to having a movement disorder specialist because movement disorder specialists are inundated with different types of cases of Parkinson's, the latest and greatest treatments, the latest and greatest exercise strategies. I believe the Parkinson's Society would also support if you have the ability to get to a movement disorders neurologist, it's probably to your benefit.
Excellent. Now, our next question coming up here is from one of our online viewers. Now, this question says, are there any specific exercises or programs that you can recommend to help delay or defer problems with walking, especially during this challenging time?
That's a great question, and I hope that the 3 future directions that I talked about during my presentation would help answer some of that. There are certainly things that we can do to try and delay some of the symptoms. Of course, any sort of activity is better than nothing. As you saw with one of the slides, there are certainly some programs that are really targeting the motor symptoms of Parkinson's. And if you have specific issues, you would want to make sure that you're looking for those programs that are actually going to deal with those issues. So for example, it's well known that Tai Chi is very good for balance in Parkinson's. Does it necessarily improve all the symptoms of Parkinson's? Not necessarily, but if that's the specific issue that you're having, then that's probably the best thing to go for. In other cases, there may be programs like PD SafeX or Rock Steady Boxing, where if you need more of a cardiovascular workout and you're trying to keep your cardiorespiratory system fit, maybe something that's much more intense, a higher level of impact like Rock Steady Boxing may be better for you. And if you're focused on motor symptoms and non-motor symptoms, then of course pick those programs appropriately. But that's what some of our studies are trying to figure out right now.
Now, can I add to that as a question for me is, could you maybe talk on some of the specific exercises or aims for PD SafeX in particular? Because looking at some of the results you showed on screen, that's fantastic. So what kind of specific things does PD SafeX do?
Yeah, so SafeX is an acronym that stands for Sensory Attention Focused Exercise. So the basic idea is that if we are aware of where our limbs are in space, and we start to make better use of that information, then we can actually try and enhance how our movements are being performed. There's a possibility that perhaps in Parkinson's, maybe the sensory system isn't sending enough information to the brain, and maybe the basal ganglia system is actually having difficulty processing that sensory information. So the idea behind PD SafeX is to try and get the proprioceptive system to drive information back to coordinate with what your vision is telling you and what your vestibular system or balance system in the brain is telling you, so that you can better coordinate your movements.
Fantastic. Now our next question is by email. So he says, how is your clinic being affected by COVID-19? And is it adversely delaying any of your research studies? And you mentioned a bit of this, but I guess maybe we can go into more detail.
It is certainly a challenge. I think COVID has affected everyone in different ways. I feel horrible for the restaurant industry. You can imagine when you're dealing with multi-million-dollar grants and you're just at the end of a 40-week study and you're so excited for the results, but then that last assessment, you just can't do it, or that blood test or that brain image that you wanted. When you can't get that last result after investing so many hours and weeks and months of training and rehabilitation, to not be able to get that result, it's been a huge issue. It is also difficult not to be in the office every day. I'm really getting tired of wearing my pajamas. Today I put pants on for you. But, you know, working from home instead of being able to see everyone, I miss you guys as much as you probably miss our staff at the MDRC. Hopefully we can do things virtually for a while. If you're interested in some of those studies, as I said, please feel free to reach out, email us, give us a phone call. We can definitely, with virtual delivery of exercise rehab programs, we can definitely offer it to a much larger population. It'll be easier for us to get our programs out to a lot of you.
Now, folks, we understand that we're experiencing some audio issues at this time, but please stay with us as we're working very hard to resolve them now. Dr. Almeida, on behalf of all of those watching, I want to thank you for today's presentation. I know I'm walking away with a better grasp of gait and motor rehabilitation. And on behalf of the Parkinsons Society Southwestern Ontario, we want to thank you for your continued support and friendship.